औज़ुबिल्लाहिमिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम अस्सलामु अलैकुम वरहमतुल्लाहि वबरकातुहू। सूरह निसा की 139 नंबर आया मुबारक। अल्लज़ीना यत्तखिज़ूनल काफ़िरीना अवलिया मिन दूनिल मुअमिनीन अयब्तगूना इंदहुमुल इज़्ज़ा फ़इन्नल इज़्ज़ता लिल्लाहि जमीआ। सदक़ल्लाहुल अज़ीम। अल्लाह रब्बुल इज़्ज़त फरमाते हैं, वो जो मुसलमानों के बजाय काफिरों को दोस्त बनाते हैं, क्या वो उनके पास इज़्ज़त तलाश कर रहे हैं, हालांकि इज़्ज़त तो सारी की सारी अल्लाह ही की है। सदक़ल्लाहुल अज़ीम। So we are going to start with a case scenario. A 30 years old male presented with episodic headache associated with perspiration. On recording, the blood pressure is 160 by 100 millimeters of mercury, which is quite high for this age. Fasting blood sugar is 250 milligram percent. Give your differential diagnosis. How will you investigate this case? Give the management outline. This case scenario is with reference to our today's topic of discussion, and that is Pheochromocytoma. And I am Dr. Muhammad Faisal Bilal Lodhi, Professor of Surgery, Surgical Unit 1, Allied Hospital, Punjab Medical College, Faisalabad Medical University. Pheochromocytoma arises from the adrenal glands, and as you know that the adrenal glands are two in number, right and left. These usually occupy a position on the upper pole of both the kidneys, and these lie in quite a deep situation just below the diaphragms. These glands are richly supplied by the blood vessels, and they normally receive the oxygenated blood from three sources. One is the phrenic artery, then one artery directly from the aorta, and the other feeding vessel is from the renal artery. So these are richly supplied, one of the most richly supplied endocrine glands in the body, and these are the adrenal glands. And the adrenal vein on the left side, it drains into the left renal vein, whereas on the right side the adrenal vein directly drains into the abdominal aorta. Coming on to the transverse section of the adrenal gland, once we traverse the adrenal gland, we can see a capsule, a cortex, and the central medulla. The cortex has got three distinct zones, and if we come from outside to inside, the outer is called the zona glomerulosa, which mainly secretes the mineralocorticoid hormones. Then the central portion is zona fasciculata, which secretes glucocorticoids, and the innermost portion of the cortex of adrenal gland is the zona reticularis, which mainly secretes the androgen, the male hormones. The innermost part of the adrenal gland is the medulla, and it secretes catecholamines. We will discuss pheochromocytoma under these four headings. What is the physiology and pathophysiology? What is its clinical presentation? How we diagnose, and what are the management steps? This is the origin of different types of tumors which arise from neural crest. These all tumors, the neuroblastoma, the ganglioneuroma, the pheochromocytoma, these are of neural crest origin, and from the neural crest, the neuroblast, which are the most primitive cells, the tumors arising from neuroblasts are called as neuroblastomas, and these are common in young children. These neuroblasts then differentiate between chromaffin cells, and these chromaffin cells then give rise to pheochromocytomas, which may be intraadrenal and these may be extraadrenal. The other form of cells which develop from these neuroblasts are the sympathetic ganglion cells, and the tumors arising from the ganglion cells are called as ganglioneuromas. All these tumors, these produce catecholamines, meaning thereby neuroblastoma, ganglioneuromas, and pheochromocytomas. These all three types of tumors are catecholamine secreting tumors. This is the pathway of production of catecholamines, and there are different metabolites in the body which are formed by different reactions. The main substrate is the tyrosine. From tyrosine, L-dopa is produced. L-dopa is converted into dopamine, and this dopamine is then under the effect of monoamine oxidase, it converts into the metabolite homovanillic acid. Then this dopamine is converted into norepinephrine, which is then converted into normetanephrine, and this normetanephrine is converted into its final metabolite, which is valinyl mandelic acid. Similarly, norepinephrine is converted into epinephrine, which then converts into metanephrine, and this metanephrine then ultimately goes into production of vanillyl mandelic acid. Please remember that this vanillyl mandelic acid is then excreted in the urine, and this concentration of vanillyl mandelic acid in the urine is a very important test to look for pheochromocytoma in the body. What are the different signs and symptoms of pheochromocytoma? Remember 5 P's. Pressure, that is hypertension. It occurs in 90% of the cases having pheochromocytoma. Then pain, meaning thereby headache. It occurs in 80% of the cases. Then excessive perspiration, excessive sweating. It occurs in 71% of the cases. Then palpitations, which occur in 64% of the cases. And pallor, which occurs in 42% of the cases. And if you can add 6th P, and that is paroxysms, meaning thereby the attacks of headache, perspiration, and palpitations, these occurs in paroxysms. That means in episodes. These are episodic attacks which occur in these patients. The classical triad of headache, excessive sweating, and palpitation is the hallmark of pheochromocytoma, and lack of all these three signs virtually excludes the diagnosis of pheochromocytoma, and this has been shown in a series of in which 100 patients were studied, which have showed that virtually absence of headache, sweating, and palpitation rules out the diagnosis of the pheochromocytoma, meaning thereby if these three signs are not there, then the patient is not suffering from pheochromocytoma. The patient might be having some other condition. Pheochromocytoma is also follows the rule of 10. 10% of these are extrarenal, 10% occur in the children, 10% are familial, that these run in families, 10% are bilateral or multiple, that both the adrenal glands are involved, 10% reoccur, and mostly reoccurrence is in the extraadrenal pheochromocytomas. 10% may be malignant, and 10% are usually diagnosed incidentally, that these do not show any features of pheochromocytoma, but on investigation for any other condition, these are discovered incidentally. One of the most important diagnostic tests is to collect 24 hours urine and check for different metabolites of the catecholamines, and these are creatine, catecholamines, metapinephrines, vanillyl mandelic acid, and dopamine. Positive results, usually we say that there is a positive result, or there is suspicion of pheochromocytoma when there is more than 2 to 3 fold elevation in either the 24-hour collection of the urine for catecholamines or metnephrines, or if there is more than 3-fold elevation of excretion of vanillyl mandelic acid in the urine. This comes to the end of part 1 of our discussion on pheochromocytoma. Then we will move now on to the second part, Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh.